So if at any point you have to run or you want to share this with anybody, it should be up on our website and our YouTube channel probably by like Monday or Tuesday at the latest. Um, I am going to share my screen. And I just want to remind you all that you are muted and off camera. So just sit back and relax. I want to share. You will notice that the chat is disabled. Um, but if you have any questions, no worries. We will save time at the end. So welcome to, oh, and you can always put those in the Q&A box. Sorry, should have finished my thought there. But I'm just so excited. Welcome to our November ALS Learning Series at the Les Turner ALS Foundation. I'm Anne Marie Doyle. I'm Director of Community Education here at the Foundation. And I just want to do a quick thank you to our sponsors, the Gilbert and Jacqueline Fern Foundation, and our industry partners, Mitsubishi Tanabe Pharma America. We know that a diagnosis of ALS can be really overwhelming, and people and family may not know where to kind of turn to next or what questions to ask. And that's where we are here to help. We have a very evergreen library of resources for people and family members that have been affected by ALS. If you're interested in viewing a past learning series that we've done, or maybe you have questions about information about ALS symptoms and care options, or maybe you're considering kind of one of those stickier decision topics, like is non-invasive ventilation right for me, or what is a G-tube? Should I get one? You can visit our website at lesturnерals.org and take a look at any of our educational materials that may speak to you. And lastly, before we get started, we always want to support our friends at the National ALS Registry. This can be a really great way to help doctors and scientists learn more about ALS and make sure that your diagnosis and you as a person are counted in the registry. So you can learn more about the National ALS Registry. Join the National ALS Registry at cdc.gov/ALS. And with that, now I'm so excited to introduce you to Dr. Howard. Dr. Howard is the medical co-director of the ALS Center of Excellence at VA Puget Sound in Seattle, Washington, where she established and now oversees one of the busiest ALS programs in the Veterans Health Administration. She also serves as the National Associate Director of Neurology for ALS in the Veterans Health Administration. And there she provides oversight for the ALS System of Care, as well as establishing and monitoring adherence to national standards of care for VAs or for veterans living with ALS. She was also an instrumental member for the National Academies of Science, Engineering, and Medicine's working group, which released their report, Living with ALS, which outlined recommendations to improve not only therapeutic development, but also enhancing quality of life for people and families affected by ALS. So welcome, Dr. Howard. Thank you so much.
Thank you so much, Anne Marie, for that kind introduction. And I'm really just delighted to be here today, especially given that this week was Veterans Day. So before I get started, I just want to express my appreciation for the service of any veterans who might be attending this call. You are the reason why I get up and go to work every day. So I hope that this information can be helpful. So I entitled this presentation, Mission Driven, How the VA Can Transform ALS Care. Because if you talk to any individual that works in a VA facility and ask them about the mission, you'll find that universally, VA employees and physicians are there to serve a mission that unites us and really gives us a reason to drive forward to make improvements in the care of all of our veterans, and particularly our veterans and families that are impacted by ALS. Before we get started, a little housekeeping. Let me make sure I can advance my slides here. Here we go. I don't have any financial conflicts of interest to disclose. I do need to say that I am speaking on behalf of myself today, and the views and opinions that I express are my own and do not represent any formal position of the United States Department of Veterans Affairs. So, starting again with the mission, I love that there's a little overlap with our audience today, in that our mission came from Abraham Lincoln himself. And the mission that we repeat, and again, you can ask any VA employee, is to care for him who have borne the battle, and his widow and his orphan. Now expand that to all sexes, because we have both women and men service members. But that is something that unites us across the country and is really transformative. And being united by that shared mission really motivates us to continue forward. So during the time that we have together today, I'd like to provide a quick background as to the ALS System of Care within the VA, to show you where we've come from. Then I'd like to, touch on, sorry, my slides are acting up a little bit today. That's not all. I'll also be talking about our current state, where we are, and some of the things that the VA is doing that are innovative, that have the possibility to truly change the way we approach ALS care in the United States and beyond. So starting back at the beginning, where did the ALS System of Care begin? And as many of you already know, there was some early literature emerging after the first Gulf War that showed increased prevalence of multiple diagnoses. Many of you will remember hearing about Gulf War syndrome and those young service members that were returning from the first Gulf War. And in addition to that, we also saw some of these young service members being diagnosed with ALS at a rate that was increased compared to what we would expect for individuals in their age range. We continue to see hints of increased prevalence of ALS within veterans in a paper that was published in 2005 by the Harvard School of Public Health. Now, this was a cancer registry that enrolled a large number of individuals, and they recorded the cause of death and then stratified by whether those individuals had a history of military service or not. This is where they found that those who had a history of military service had a greatly increased likelihood of dying from ALS compared to those who didn't. And that was the same regardless of their era of service or their age or birth cohort. The VA asked the Institute of Medicine in 2006, which is now known as the National Academies, to review all of the literature up to that time regarding ALS in veterans, to make a determination on whether there was correlation between military service and ALS. In 2006, Institute of Medicine published that report, concluding that there was limited but suggestive evidence of this correlation between military service and ALS. And as a result, that was handed back to the VA. The VA made the decision in 2008 to make ALS a 100% presumptive service-connected condition. I've included some photos of veterans with ALS in this presentation with their permission, because again, everything that we do is centered on our work with our veterans and their caregivers with lived experience. Now, VA was paying attention to ALS in veterans even long before this time, and I just want to share an interesting paper that dated back to 1980, looking at ALS in veterans. This was a much older cohort of older veterans from World War II. And they started to describe potential exposures that may have been related to development of ALS in these service members. They noticed some discrepancies in diagnosis based on race, as well as occupation, history of trauma. So this gives you a little hint of already what was possible looking at the resources of the data within the Veterans Health Administration. As I mentioned, we had additional studies that came out in the 90s describing the data following the Gulf War. And then moving into the 2000s, the VA actually established the very first national ALS registry in this country. I'm so glad that you heard mention of the CDC ALS registry. You might not know that that registry was based upon the model that was established by the VA between the years of 2003 and 2008. So if the very first registry and cohort of ALS cases was carefully combed through, I talked to some of the neurologists that helped to put this registry together. They told me about combing through paper charts at that time. Those records went back quite a long way. But this is really helpful for our VA clinician scientists to look at potential factors related to time to diagnosis, as well as factors related to survival. This resulted in a few publications looking at ALS in the military population. So what happened after 2008? I mentioned ALS became a 100% presumptively service-connected condition. We subsequently saw a massive influx of veterans that were establishing care for the very first time in the VA only after their diagnosis of ALS. And there, unfortunately, wasn't any guidance as to where that care should be delivered, how it should be delivered, and there wasn't any specific funding authorized to provide the care that was needed by this new population of high-need veterans that were entering the system. So what resulted was a very organic and heterogeneous array of clinics. Any facility like my own, my career really mirrored this transition as we saw ALS become service-connected and a large ALS population enter the VA. Every facility decided how and where they would deliver care for ALS. So we now have a very diverse array of where ALS clinics are located in the VA. About close to 40% of our clinics are housed in neurology clinics, which is similar to the community, whereas the other over 60% of clinics are housed in other departments like rehabilitation medicine or spinal cord injury, and a smattering of other departments like pulmonary medicine, for example. This is one factor that already portends how ALS care will become unique within the VA. Over time, we began to adapt and become better organized in how we address ALS care. Finally, in 2014, 6 years after ALS became a service-connected condition, the very first VA ALS handbook was published. And this handbook was quite unique. You can Google and look this document up from 2014. It provides a framework. It suggests that ALS care should be delivered in a comprehensive interdisciplinary approach, similar to the model that was established by the Spinal Cord Injury System of Care. And then in 2021, that handbook was upgraded into the very first VA ALS directive. The difference between handbook and directive: a handbook gives some suggestions. It shares what the best practices and clinical practice guidelines are for a condition, and the directive provides requirements that are binding for each facility to provide specific care. So among the changes that were enacted in 2021 with the first ALS directive was that each one of our 170 VA clinics across the country would need to have a specified point of contact for ALS, and each region, which is known as a VISN, or Veterans Integrated Service Network, would have at least one multidisciplinary clinic for ALS. So this was a large change. About the same time, we also began to hear the voice of our veterans with lived experience. And I want to highlight one veteran in particular who really changed the way that we approach ALS care in VA. And that was Shelley Hoover. Shelley Hoover was an advocate that had partnered with Sandy Morris in the ALS community. And she's a Navy veteran with a doctorate in education who took it upon herself to reach out to the National Program Office of Neurology on a weekly basis for 8 months until she got a response from the leadership to engage the community of veterans with lived experience. She also kept the Undersecretary of Health's office on speed dial and arranged meetings with the Undersecretary of Health for the VA as well. Again, she was looking for representation of veterans with lived experience in all places where decisions were being made regarding their care. And I'm going to take a step back for anyone who's not familiar with the Morris ALS principles. This is named after Sandy Morris, who is an incredible ALS advocate, likely known to many of you. They have a website that outlines the Morris ALS principles, again, stating that no decisions should be made about the ALS community without taking into account input from the community of persons with lived experience. They take that a step further by outlining principles that should be adopted by healthcare professionals when caring for individuals with ALS. This was a game-changing moment for us within the VA's ALS System of Care. And we took that, we invited Shelley to join our groups to meet with our ALS leadership, and we continue that to this day. We have representatives from veterans with lived experience, as well as caregivers with lived experience at each of our leadership meetings for the ALS System of Care. And it's a formal membership as part of our leadership committee. We wanted to get a broader representation of input from our veterans and caregivers with lived experience. And so we partnered with the Veterans Experience Office in 2023 to carry out a formal service blueprint and journey map for ALS, starting at time of onset of symptoms and continuing on to end of life. We interviewed 85 individuals, including persons with ALS, who were veterans, caregivers, clinicians, as well as patient-centered organizations. And we used all of that information from these interviews to map out the important steps along this journey, as well as highlight the bright spots in their experience working with the VA, as well as the pain points. And we found 5 key areas where we had opportunity to improve the services that we're providing, including streamlining benefits applications, strengthening the partnership between research and clinical care, enhancing our community partnerships, and improving veteran and caregiver support. The same year, we had an integrated project team that brought together leadership across all of the program offices that represented that very heterogeneous array of programs and departments involved with ALS care to come together to outline the current state and develop resources to help these new ALS coordinators to do their jobs to support veterans at each facility, as well as to create a future plan for how we could run a more cohesive system of care for ALS within the VA. In performing our environmental scan, again, we confirmed what we had suspected, that we had a lot of heterogeneity in clinics and services. In some of our facilities, we are providing world-class care that meets or exceeds anything that's available in the community. And then we have other places that are deserts where we don't have the same level of services. We had a lot minimal means to communicate across our system of care because of having a lack of infrastructure or funding. And there are gaps in developing the workforce that we need to really deliver care to our entire system of care. So this was very helpful to inform our leadership about where we were and what we would need in order to advance to a better, more equitable state where any veteran, regardless of what their zip code is, would have access to the same high quality care across the country. We also discussed leadership with these multiple service lines across the VA that were each playing a role in ALS care. A decision was made that the neurology program office would maintain chief leadership for the ALS system of care. Pictured here, you'll see me on the right of the screen, our National Director of Neurology, Cheryl Martini, who's based in Houston in the center, and then Leah Darling, who is the National Program Coordinator for the VA's ALS System of Care on the left-hand side. She's a social worker by background and coordinator at the Indianapolis VA ALS Clinic. So at the current state, this is our ALS leadership in the VA. We still are operating on borrowed resources. The goal is in the future state for us to have a dedicated program sub-office that can help support this broad ALS system of care across the country. As I mentioned, we created resources that would help these 170 ALS coordinators access information at their fingertips to best support their veterans. And we also created an educational video for our clinicians and frontline staff. If we have time at the end, then maybe I can share that, or I can direct you to where you can find that. So that brings us to today. So at current state, we have approximately 4,000 veterans at any given time that are receiving their ALS care within the VA. As I mentioned, we have 170 VA facilities, and there are coordinators that are named at each of those facilities to act as a liaison for those veterans with ALS, either at clinics within the VA or to help them in accessing ALS care in the community through the VA's community care program. We currently have 12 certified centers of excellence for ALS within the VA and 5 recognized treatment centers. In addition, there are 49 fully staffed ALS interdisciplinary clinics. So that brings us to 66 top shelf full ALS clinics across the country. I almost want to pause at that number because that is an enormous system of care, again, that it developed organically because of the desire of clinicians in the VA to provide the standard of care service for our veterans with ALS and their families. We have 35 limited ALS interdisciplinary clinics on top of that as well, that provide partial services, which are supplemented by referral up to larger ALS centers or out to the community. And this is a map showing where our certified and recognized centers of excellence are located. The states with certified centers of excellence are in red, and the recognized treatment centers are in green. So you can see that we have a fair geographic distribution. This doesn't mean that these are our only high quality centers. We have many VA centers that have not pursued certification or recognition as centers of excellence that still provide outstanding high quality ALS care. But this is just one measure from an external body of high quality. In addition, one of the things that makes the VA somewhat unique is our identity as a learning healthcare system. And if this is a term that you haven't encountered yet, I've pasted the definition from the Agency for Healthcare Research and Quality. A learning healthcare system is a system that adapts to both evidence-based practice, but also using experience, quality improvement, and internal data to rapidly improve care and put knowledge into practice as quickly as possible to provide more efficient, higher quality care. And also improve the health of the organization as well, enhance the healthcare staffing that we need to deliver this high quality care. And a few examples of how the VA is a learning healthcare system for ALS is in how we navigate our internal data. Again, we're the largest united healthcare system in the country. We have the largest united electronic medical record in the country, which provides a lot of data that we can utilize to help improve care in ALS. Way back about 10 years ago, we built a dashboard to look at our population of veterans with ALS. This is at my home facility in Puget Sound. Just giving a little snapshot with the names redacted for privacy. And we expanded this through a beta test to explore how a dashboard could help us manage our patient population at a glance. You can see in this example, for example, we monitor labs for patients that are on riluzole. And at a glance, we can see individuals who have abnormal lab function. We can see the breathing test results at a glance for our population. And then we have further columns that indicate whether someone has respiratory equipment like a BiPAP already issued, cough assist. And so we can identify individuals that need to have equipment based on their lab results. We have percentage weight loss, whether that individual has a feeding tube, when they had swallowing screening done, cognitive screening, their ALS functional rating scale, and then finally when their clinic visits are. So we could quickly sort and identify those who need to have a follow-up appointment scheduled. So this is just one example. In present state, we have a national monthly data pool that identifies all individuals who have a diagnosis of ALS in their record. This is divided up by a facility and region, and it's sent out to those coordinators so they can see who in their catchment area has a recent diagnosis of ALS. We see the date that that diagnosis was entered into our system, and we can identify other factors like do they have 100% service connection rating? In this example, here's one row at the bottom where that person doesn't have 100% service connected rating. And so that can be an alert to the coordinator that that person might need some assistance with their benefits. We're expanding this dashboard this year to include a few more initial quality metrics that will help give us a snapshot of elements that we think should be present in high quality ALS care, such as whether genetic testing has been performed, whether that individual is scheduled in an interdisciplinary specialty ALS clinic, as well as looking at time to diagnosis, and respiratory evaluations as well. So moving on from clinical care to research, our research also helps to inform our practice. And as I mentioned, within the VA, we have a very robust system of care, but we also have a very robust research program. The VA Office of Research and Development celebrates its 100th birthday this year. And annually, VA has about $2 billion in research funding. About $1 billion of those dollars come from VA-specific funds for research, and about $1 billion come from external grant funding like the National Institutes of Health. Looking at a snapshot of just 1 year, in this example, 2024, the VA published almost 12,000 research articles. It was either authored or co-authored by VA researchers. And we have 100 research sites across the country. So we're doing a lot of research activity within the VA and supported by Veterans Affairs. Specific to ALS, we have about 22 funded research projects under the Office of Research and Development. They span the gamut from basic bench science, basic science research, looking at the mechanisms of ALS that can help identify potential targets for treatment, all the way up to very complex rehab research, such as nerve stimulation to help improve neurologic function in the spinal cord for individuals with ALS, and brain-computer interfaces. I have a tiny picture on this screen of our one clinical trial site that was activated last year in Houston, Texas, which is really exciting development we hope to see more of as well in the future. As I mentioned, as a learning healthcare system, not only do we incorporate evidence from research and use the data that we have at hand to inform our care, we also share best practices, and we share what we learn with the community as well. Some of the work that we've done in the past few years is incorporating our best practices for managing the transition to invasive mechanical ventilation with a tracheostomy, and what care and education should be delivered before, during, and after that procedure, as well as evaluation for someone surrounding feeding tube placement and what things we do to ensure the highest level of safety before, after, and during that procedure as well. Our clinicians have contributed to National ALS Home Health Guidelines, which I'm hoping we'll be seeing released over this next year. They're currently being vetted by one of the national professional organizations and should be published to provide best practices for supporting individuals with ALS in their home. So we're using the knowledge that we've gathered from working with veterans, meeting with our colleagues in the community in the private sector, to share those best practices to help continually improve the care that we provide. On the right of this screen, you'll see a checklist. This comes from our invasive mechanical ventilation with tracheostomy standard operating protocol, providing a checklist of all the equipment that should be issued before someone is discharged from the hospital with a new ventilator with tracheostomy. We have training checklists for the caregivers, as well as this checklist, which covers what needs to be evaluated about the home to prepare for bringing somebody home on a new ventilator. So again, a few examples of ways that we try to share our expertise among our centers and beyond. So getting back to what makes the VA unique, I've mentioned a couple of times that we apply a rehabilitative approach to care, that was cornerstone of our ALS System of Care when the first handbook for ALS was published in the VA in 2014. Another unique aspect of that is that the care that we deliver is proactive and anticipatory. Now, what does that mean? So within the VA, we try to anticipate or expect the changes that are going to happen in our patient's function and provide the equipment so that they already have what they need before they have the loss of function. Now, this is completely opposite to how commercial insurers and Medicare, Medicaid traditionally work, which is in those cases, someone generally has to lose the function first, and then they can get the equipment that will help them get around and function after that loss of equipment. And because there are time lags in getting authorization for equipment, being evaluated, having equipment delivered, that leaves patients and families in a lurch when they needed to have a lift yesterday, but they can't get it delivered until a week or two after. And that just doesn't make sense in ALS when we know what to expect. And so it's a different model. We think that every person, family that are impacted with ALS deserve to have this type of care. And so we've used that experience to advocate for the community to have the same approach, because the diagnosis of ALS should be enough in and of itself to justify any equipment that that individual may need over the course of their disease. So again, this is another example of how our rehabilitative approach, I've put a couple of examples of other rehabilitative systems of care within the VA, such as multiple sclerosis, polytrauma or brain injury. I mentioned spinal cord injury and amputation care. These all involve highly integrated collaborative team approaches with an emphasis on maximizing function and quality of life. And you might not be surprised to hear that of all these diagnoses, we'll see our veterans participating in events such as the National Veterans Wheelchair Games, where they're competing with adaptive equipment in events such as adaptive bowling, or shooting, or adaptive cycling is one of our most popular sports. So it's really an emphasis on not what you can't do, but rather what you can do with a diagnosis of ALS, with additional support and equipment. We also have incorporated the use of virtual care or telehealth for our patients with ALS, including therapies. So one of the programs that we run out of the Seattle VA is a virtual exercise group for individuals with ALS, which is very unique. It's not something that's widely available out in the private sector, but we found a lot of value in bringing people with ALS together in these exercise groups. Now, you heard a little bit earlier in the introduction that I had the privilege of working with the National Academies Workgroup in 2023 to 2024 to put heads together with an incredible array of individuals with expertise in many different fields, as well as with lived experience of ALS and experience of the pre-symptomatic genetic carriers, to outline the current state of ALS in the United States and to make recommendations on truly advancing ALS research and care across the country. So I was a representative from the VA. On this photo in the bottom right, Dr. Jerome Current from the Charleston, South Carolina VA and the Medical University of South Carolina was also a VA representative. And this is us pictured with Suma Babu from Mass General Hospital, who was another participant in the National Academies Workgroup. So the report from this was released in last year, in the summer of 2024. And one of the things that I didn't expect from this report was that the VA was cited as a bright spot in the landscape of ALS care and was lauded for a few of its key elements, including the fact that it's providing interdisciplinary care that's proactive, as I mentioned, and justified a few slides ago, and patient-centered. And I've included a QR code if you haven't had a chance to take a look at that National Academies report or download it. It truly provides a roadmap to a better future for ALS, both in research and clinical care, and improving quality of life for both persons with ALS as well as their caregivers, and for the pre-symptomatic genetic carriers as well. Now, the VA didn't get a pass in this study, and in fact, the VA was rightly called out for areas in which we can improve, some that I've already mentioned in this presentation. And that was to ensure that there's equitable access to high quality care for all veterans across the country, regardless of where they live. And also playing a role in addressing the workforce shortage that's impacting everyone across the country, not only in the VA, but also in the private sector. One thing that I didn't touch upon, but I think is really important, is the central role that VA plays in education and educating clinicians that go out to practice in the rest of the country. Now, between 70 to 80% of all physicians that are practicing in the United States trained in a VA facility. So we have a very unique opportunity to help educate the future generation of healthcare clinicians, not just physicians, but across allied health professionals. And we have massive training programs for nurses, therapists, psychologists, and all allied health professionals. So there were very specific recommendations to the VA to help increase resources to address the multiple parts of the VA mission. I talked about the overall mission, but that's broken down into three main goals: to improve clinical care, research, and education. Now you saw a map of where our centers of excellence and recognized treatment centers are. One of the suggestions from the National Academies report was to use a hub and spoke model of care to ensure that smaller clinics would have access to tertiary medical centers, to ensure that all individuals with ALS would have access to high-tech interventions to improve their function, as well as research opportunities. So that's the model on the left, came from the National Academies report. And this overlaps very well to the already existing hub and spoke models. This is an example from the VA, from the spinal cord injury system of care, and the hub and spoke that's been in place for many years now, which serves those exact purposes. So a few of the things that we're working on moving forward. Again, we have learned so much from engaging with our community, and we've committed to increasing our transparency in order to try to help level the playing field and ensure equitable access to high quality care for veterans across the country. Over the past year, we were able to launch an externally facing website. I have the QR code for that website here on this slide. This provides quick link access to information on how to get started to access clinical care and benefits. It also provides an updated link to a directory of all of our 170 sites and the ALS coordinator that's assigned to each of those sites, with direct phone numbers to those coordinators, as well as a link to our directive. So I mentioned our first directive was published in 2021, and we will have an updated directive published in 2026. These are on 5-year cycles. So do stay tuned. When we get that new directive, we'll be linking it onto our website. We've also learned to really value and leverage these partnerships with our community. I hope this is one example of working with our incredible colleagues at Les Turner. We are so grateful for the collaboration and sharing of resources. It really makes all of us better when we're all working on the same team. We continue to have listening sessions and to elicit input from our veterans with ALS and their caregivers. Last year, we sent out a questionnaire to all veterans in our system with ALS for whom we had an email address and asked for their input about their perception of the ALS care they're receiving. And now that our shutdown is over, thankfully, we're hoping to send out a new questionnaire. So if you're a veteran, make sure that your email address is updated in our system, and we would love to invite your feedback on how we're doing and what we can do better. And we have some formal partnerships with the National ALS nonprofits. We have formal memorandum of agreement with the ALS Association and ALS United to ensure that care service coordinators are able to connect to our veterans within our clinics seamlessly without any bureaucratic barriers that prevent us from collaborating. So again, here's another snapshot of our website. Please do check it out. The URL is pretty straightforward, so please share it with anyone. And to sum up, the thing that makes the VA ALS System of Care unique is the fact that we're united by our mission and by reinforcing Abraham Lincoln's promise to our veteran and caregiver community. We have come a long way in the 16 and now 17 years since ALS has become service connected, and we realize that we still have a long way to go, but we are committed to this mission and increasing our transparency to share our progress as we move in that direction. We have some unique highlights of our system, and we're doing our best to share what we learn to help enhance ALS care for everyone, whether veteran or non-veteran. And a lot of that is to do with the fact that we're a learning healthcare system, allowing us to rapidly adapt and improve our practices of care. Our goal is to become a model of high quality and equitable ALS care, both nationally and internationally. And I think I have a little time, if I can. I'd love to share a quick video with a little bit more information about our approach to care, highlighting one of our veterans and caregivers with lived experience. So I'm going to try to launch this and share the audio. Please bear with me. Just make sure my settings are set properly. It's not you, sorry. Tell me if you hear the audio if I click this.
Ooh, I don't.
Okay, let me hang on one second. I'm going to just do a new share. And let's see. Oh, I'm really terrible at this. So I might not be able to do it. That is okay. Um, I will leave it to you. Uh,
Dr. Howard, thank
yes.
you so much. Um, what I can do on my end is if you send me the link to that, we'll include it in the notes when we upload today's program so everybody can get a chance to see it because, oh my goodness, I mean, look at that little
Super
peanut
cute.
face.
Yes, and it is the video is also linked on the top of our VA external website as well. So if anyone caught that QR code, you can hop over to the website and you can check it out. But thank you so much, and I'm so glad we have a little time for questions. I'd be
Yeah.
really happy to answer any questions.
Absolutely. And for anybody who might have missed that QR code, I haven't. So I will also include that in the notes as an additional resource. So if you click that, you'll be able to go straight to the website Dr. Howard mentioned, because we want to make sure everybody can get all the information that was shared today. One thing that I just want to highlight, my background in a past life is in rehab medicine and specifically speech pathology. But I really loved how you emphasized the VA's commitment to being more proactive than kind of reactive. It's something that I think all of us could really advocate for. So that's really exciting to hear how the VA is supporting ALS and people living with ALS and highlighting what you can still do versus kind of reacting to the things that continue to change, which is great to hear. One question that had popped up, and feel free to put any questions in the Q&A. Um, is what about, so you mentioned a little bit about research that the VA is doing. If I'm a veteran living with ALS and I'm getting care at a VA, how else can I connect to clinical research?
Fantastic question. So again, that's one of the areas that we're really trying to improve and standardize. We asked last year to our veterans by the survey that we sent out whether they were receiving education about research during their ALS clinic visits, as well as a multitude of other topics. And we were knocking it out of the park on so many areas, but research was a place where we really could do better. And so over the past year, we've invited many speakers from organizations supporting research, including the Northeast ALS Consortium, All ALS, to come to speak to our VA clinicians to provide us more resources to help our veterans who are interested. And we're going to hold ourselves to it this year. We'll follow up with our veterans to make sure that we're improving in introducing research in our clinics and and get more information out there. So for our veterans coming into our clinics, I do encourage individuals to ask those questions when they come in. Most of our clinicians in VA have joint appointments with their academic affiliates, and many of them go back and forth between the university and the VA, which really helps for cross-pollination and opens up more opportunities to participate in clinical research at either the VA or the university that the clinician is affiliated with. So I would always start with your clinical team, because they are likely the most plugged in to your area and what's available locally for you. And we really want to try to reduce burden of traveling on top of everything else in order to participate in something altruistic like research. There are some VA specific research opportunities, and some of my veterans are very interested in helping to be part of finding the answer to why ALS is impacting veterans more than the civilians. So, one of these resources that I think is really incredible is the VA ALS Brain Bank and Tissue Biorepository. This is based in Boston, and it involves the same researchers that participated in the NFL Brain Bank, looking at football players, which a lot of people have heard about. These are incredibly talented academics and neuropathologists. And veterans from any state can enroll in this tissue biorepository that accepts donated tissue after someone passes away, and then keeps that, makes it available to researchers that are looking for answers about ALS and veterans. And they're a wonderful group to work with. So that's another unique resource that I want to highlight.
Oh, that's fantastic. Thank you so much because I know that's always a question that pops up. Um, and there's not super great information right now that I can provide folks or civilians about end of life tissue donation, but absolutely, definitely want to highlight the VA ALS Brain Bank and Tissue Biorepository. That's an incredible program that shows really great collaboration. Oh, wait. Another question was, what can we do as advocates to support the VA and all of the providers? What can we do to help support you guys or collaborate or further advocate for support?
I really appreciate that question. I unfortunately have to abide by our Hatch Act restrictions, and as a federal employee, I cannot ask
Sure.
for other individuals to represent to our lawmakers on behalf of our federal institutions. So I just want to express appreciation for having open collaborations to talking about what our current state is in the VA. I'm really also grateful to the National Academies who did a lot of the work for us. They wrote out the recommendations and they said, here you go, Congress, here you go, Medicare, Medicaid, here you go, commercial insurers. This is the roadmap. This is the consensus of what we think that you need to do. So that is a wonderful resource that was developed by an outstanding group of individuals with a really united mission to advance ALS care. And I think that it's important for all of us to become familiar with those guidelines and to use that blueprint to move forward.
Absolutely. And I think advocating for this system of care and this type of care that could then be mirrored for, the civilian population. I think that that would be an incredible, incredible missing piece for ALS clinics. And the last thing, which I think is definitely worth mentioning, um, and if I didn't get to your question, I apologize because I want to be mindful of time. But I will email and follow up with you all that had questions. But somebody had mentioned that they are connected to the Paralyzed Veterans of America group, and that group is kind of helping them get connected to VA supports. And I just want to make sure that everybody on the call is aware of that. That's a great group. And any other advice regarding getting connected, or would your would you say the PVA is a great first stop?
We have a number of veteran service organizations. PVA is one of them. I can't recommend one
Oh,
over
sure, of course.
the other, but we have an incredible history of collaborative partnership with PVA. I'm very grateful for the support that they've provided to our veterans. Working with a veteran service organization can be really helpful to navigate. We understand that the number of forms that a family has to complete after a diagnosis is just an unbelievable, something that we're advocating and working with the other side of the Veterans Benefit Administration, which is a separate entity from Veterans Health Administration, where I work, to try to make that process easier. They're aware that things need to change to make that easier for our veterans and families. If you ever get stuck, and if I didn't answer your question, because I know I can talk a lot, we also have a direct email, alscare@va.gov. That comes to our very tiny little program office of two. And if you get stuck and you can't find the point of contact at your local facility, please reach out, and we're here to help.
That's a great resource, and I wrote that down. We'll add that to our list of resources. And then promise last but not least, and I don't know that we have an answer on this, but did want to just bring to attention, I know that there's a bill that is currently advocating for the length of time a veteran must live in order for a spouse to retain benefits, and I'm blanking on the name of that. I don't know that we have an update on that, just given that the government was shut down and it just reopened. But I think that would be something that we'll continue to advocate for. And highly recommend contacting your Congress and state legislators who represent you in Washington to further support that and gain traction. All right,
Uh,
everyone. Oh, go ahead.
I really appreciate you inviting me here. And again, I'm here to serve as a resource if there's anything that I can assist with. And again, thank you to all of the veterans who attended for your service, and thank you for allowing us to be part of your journey.
Yes, thank you so much, Dr. Howard. Everyone on this call, thank you for giving up your afternoon. We really appreciate it. Next week, we have a rescheduled ALS learning series. So if you are looking for our learning series on ALS and constipation, that was rescheduled to next week, which will be another can't miss. In the meantime, happy belated Veterans Day. Thank you all for the veterans on the call for your service, and we hope everyone stays well. Have a good one.
Bye.
Bye.